Okay, all right, we're back with part two. Let's see if I can get my slides working, and then we'll rock and roll. Okay, so we talked about IO placement. We're still in IO section. I know I broke it up weird, but we were coming on 26 minutes, and that was just too long. I know attention spans, are what they are. This is a cool up and coming protocol. I think it's really cool. I'm really excited to use this on somebody one day. But basically, this was a protocol developed by EMS in San Antonio, where I live, and I think it's something that will hopefully, I'm not gonna say come to the forefront, but it is something to keep in your back pocket when the person's dying and you can't get IV access and you can't really thread the catheter and get what you need to give them the stuff that they need. So this is called Mind the Gap. I spelled it wrong down here, as you can see. That's a typo on me, which I didn't catch in my pre-editing, but what can you do? So it's called Graduated Vascular Access for Hypotensive Patient. The primary author is Matt Saab, super nice guy. Emily Wright, super nice lady. Josh Lowe, Ian Hudson, Eric Jacobson, Adrian Long. I know all of them. They're all super awesome, all super great, dedicated to the cause, dedicated to helping people, dedicated to combat trauma. Really great people to work with. So I just happen to know all of them. And I didn't put that in because of that. I put it in because it's a super cool protocol that I'd never seen anything like that before. So basically, what they're doing in this protocol is this. This is not in the Teachable Z guidelines, by the way. This is for a patient that you can't get IV access on, and what they're discussing in this protocol and what they studied was basically putting an IO in somewhere, instilling it with a fluid bolus to plump up more proximal vessels to then aid in obtaining IV access. So what does that actually look like? So let's just take the axillary vein, for example. So it's here in the clavicle. What they're talking about here would be to put a humeral IO in, give a large fluid bolus through that, and that will take the vessel from looking like this tiny little vessel to a big, juicy vessel that you can get IV access on. In this case, that will be central access. In the femoral vein, that would also be central access. So, you have to have the skills to get central access regardless, maybe even require ultrasound, you never know. But that's what they studied. They studied putting an IO in, and what did the volume of the the more proximal vessel look like? That vessel got much bigger, a much, much, much larger vessel, and a much easier target to hit when they instilled the fluid bolus in. So for this one, axillary vein would be humeral IO. The cephalic vein here, which would be a PIV, a medic can totally hit that, nurse can totally hit that, would be this distal radius IO, and that's the pictures that you see here. Femoral vein would be distal femur, and this is again central access, so you got to have the skills. And then this one will be distal tibia near the medial malleolus, just proximal to the medial malleolus. And then you can plump up the saphenous vein and get peripheral access. Saphenous vein is a good, often forgotten IV access location. So 4 sites there. They did a cadaver study on there. I think it's super cool. I talked to one of the authors just the other day. I talked to Josh Lowe and just said, hey man, I want to teach this to my medics. I think it's a really sick thing to be teaching people, but I don't want to go in there looking like a moron. Have y'all actually done this in the field, live patient, real world? And he said yes. He goes, it's not that many, but we have done it for patients who they just couldn't get access any other way, because even people who have really massive hemorrhagic shock, just getting even central access can be very difficult, even for the best trained medics and physicians. So it is not in the full San Antonio EMS protocol as of yet, but it is an option that they need to call a medical director for, and then they can do it. So it's out there, maybe getting more popularity with time. You'll never know. I think it's cool though. All right, next guideline, TXA. Everybody loves TXA. If a casualty will likely need a blood transfusion, for example, they're in hemorrhagic shock or has one or more major amputations, they have penetrating torso trauma or evidence of severe bleeding, or the mental status associated with blast injury or blunt trauma is bad, administer 2 grams of TXA via slow IV or IO push as soon as possible, but not later than 3 hours after injury. Okay, everybody has TXA on their, meds to know list, and it's on the World Health Organization list of just the world's greatest medicine ever. And so, what do I think about TXA? I think I learned something new about TXA. We're not going to do that yet. While doing this talk, which was, I didn't realize how old TXA was. First synthesized in 1962 by a pair of brothers, which was kind of interesting to me because I like to nerd out on stuff like that. Don't butcher me, don't murder me when I tell you these names, but they are Shishoke and Utako Okamoto. They were Japanese, synthesized in 1962. They were two brothers looking to solve one of the major problems that plagues the earth, which unfortunately is mortality surrounding delivery of children. So like maternal mortality due to hemorrhage. And so they basically synthesized TXA and discovered it for the world. How does TXA work? This is what TXA looks like in America. Most of the places I've seen it looks just like that. TXA basically stops your blood clots from breaking down. Okay, that's the goal. So your body is in a perpetual battle between bleeding and clotting. Your body doesn't want to bleed too much, but doesn't want to clot too much, and so it has things in your body that make clots and things in your body that dissolve clots, and they're in a constant balance. We've already talked about the coagulopathy of trauma, how that can become very unbalanced. And TXA, I won't say helps to correct that balance, but TXA the goal is to prevent plasminogen from converting to plasmin, and plasmin's job is to break up the fibrin clot. One of the main proteins that causes clot formation is fibrin, and when you don't let plasminogen convert to plasmin, you have decreased clot breakdown, essentially. So giving TXA lets your clot do its thing instead of breakdown. That's the theory, and it does work. Okay, so this is, I should start doing something when we have a landmark paper. Landmark paper alert. This is a landmark paper alert. Landmark papers are practice-changing papers that every doctor should know, every nurse should know, every medic should know, because they change our practice for in a major way. And this is one of them. I mean, CRASH 2 was a major trial done, published in 2011. I don't know if any of the articles we've done have been from the Lancet. They're usually from some just bizarre German injury journal that I find, but the Lancet, arguably the most prestigious medical journal, that and the New England Journal of Medicine, they are both super, super famous. And so this trial was so important that it was published in the Lancet, which is a big deal. And the overall thing was basically, if you give TXA, does it work? What are the effects on death and vaso-occlusive events? That means like blood clots in your vasculature, and then blood transfusion with trauma patients with major hemorrhage. And the answer was yes. TXA does work in trauma. It has some no's for other stuff and then some caveats. But this one was just for trauma. So basically what they really found in this trial was a 1.5%, absolute risk reduction in mortality. So 1.5% of people, I shouldn't say absolute risk reduction, it was a 1.5% decrease in mortality at 30 days of the people who got TXA. Now they did a 1 gram bolus and then 1 gram infusion over 8 hours after that. There was a decrease in mortality at 30 days. No difference in the amount of blood transfusions that people got. There was no difference in the amount of surgeries that people needed. And there was also no increased events of DVT or stroke or pulmonary embolism, stuff like that. And so stroke's not really a vaso-occlusive event, but it sort of is. But there was no increase of DVT or PE. And that was always the risk that people had said is like, well, if you give TXA, people are just going to get DVTs and they're going to have pulmonary embolisms and they're going to die. And they're not going to die from their trauma, but they're going to die of a blood clot in their lungs. That's like not true. You see in the guideline, don't give it after 3 hours of injury. Okay, where does that come from? That kind of comes from this paper. They found that people who got the TXA after 3 hours did worse. There's a lot of theories behind that. Some people who don't buy into that, they say that that's BS, that that's dumb. Don't buy into that. I don't know. Either way, it doesn't seem to make sense to me, but there are some scientific theories. I can't say that I have found any paper ever that said, here's why they die more, or if this was just study noise and they just found that in the study, but it's not necessarily the truth in the universe. I don't know. So fortunately where I work, most people come within a certain amount of time after their injury, so I don't have to worry about that. This was a massive study, 20,000 patients, so lots of data, essentially. Cool. There you go. CRASH 2. Now you know it forever. Its competitor, the New England Journal of Medicine, arguably the most prestigious between them and the Lancet, they did another trial. This one is much more new and says, okay, well, I know that TXA has decreased mortality, but does it really improve outcomes later? Like if you get TXA, are you like better off than if you didn't, if you do happen to survive? And that's an interesting question. So sometimes they do stupid studies that say, well, how many days were they in the ICU? Or like, how many days were they on the ventilator? Or what is the cost? Okay. Dude, patients, like when they're dying, they don't care about the cost. They don't care how many days are in the ICU. They don't care how many days are on the ventilator. They want patient-centered outcomes, which is like, did I get to keep my leg? Did I die? Um, do I have to be in a wheelchair forever? Functional outcomes, neurologic outcomes, those are more important to patients than like how many days they're in the hospital. Are how many days are in the hospital totally irrelevant? No, of course not. Nobody wants to live in the hospital for 6 months because they didn't get TXA. But it's more important if is the ultimate question of like, did you die or did you have to live as a vegetable forever? Unfortunately, so they looked at this. This was 1,300 patients, Australia, New Zealand, Germany, all trauma patients, high-level trauma systems. They received TXA within 3 hours. They measured functional outcomes at 6 months, and they found no benefit to TXA compared to placebo at functional outcomes at that 6 month time. They talk about some like worse neuro outcomes actually, meaning that like maybe people who would have otherwise died, potentially survived because they had received TXA, and then their ability to take care of themselves was much lower. And so it raises these interesting like ethical dilemmas of like, should you save people that are super disabled? And there's no answer for that. I think you should. I think you should give TXA. But the paper has some interesting graphics here. Survival with functional neurologic outcomes. So there was no difference. Okay, there's no difference in survivability with a favorable outcome. Here they repeated essentially the CRASH 2 findings of you die less when you have received TXA when you were a trauma patient. So, I mean, this early, so early is best, right? The early outcomes are the best. Within 24 hours, I mean, that's like 5% almost. This is, 4%. This is, gets a little squirrelier as you go. That's about 4% too. So that was within 24 hours, 28 days, and 6 months. So people die less when they got TXA for their trauma. And then vaso-occlusive events. This was not statistically significant. So although this number is bigger than this number, there were no more like DVTs or PEs or whatever. So nice little graph. I don't do graphs. My brain doesn't really work on graphs, but my brain can tolerate that one. This is what they wrote, and I found this really, so like if you do enough, whatever this is called, PowerPoint, they will start to suggest design ideas for you, and then I found this design idea to be particularly hilarious because we're talking about severe disability, and they thought a wheelchair would be a good thing to throw in there. So the AI is, I don't know, has a sarcastic sense of humor, I guess. But is it an ethical dilemma or not? This is a direct quote from the paper. I didn't write this. I just copy and pasted it. In our trial, for every 100 patients assigned to receive either tranexamic acid rather than placebo, there was approximately 4 extra patients alive at 6 months. That's awesome. Semicolon. However, approximately 4 extra patients were also recognized as having severe disability. So, is it ethical to save someone that's going to have severe disability? The answer is you don't know. You don't know that they're going to have severe disability or not. And so I think the answer is you do the best you can with every patient that you got, knowing that you're not God and you can't predict what their outcome is going to be like. But if you don't give them the chance to have a good outcome, then they're probably not going to have one. So I'm skipping ahead. But here's my bottom line. I give 2 grams TXA bolus for trauma patients in hemorrhagic shock or at risk for hemorrhagic shock. These are the caveats that I mentioned earlier. I do not give it for GI bleeds generally. That's a different CRASH trial. I believe CRASH 3 looked at GI bleeds, or maybe CRASH 3 looked at intracranial hemorrhage. I can't remember. I think maybe it was intracranial hemorrhage. But there was some studies on TXA for GI bleeds and intracranial hemorrhage, and it does not seem to be beneficial for those. There was some sub-analysis on those that got a little squirrely and maybe too complicated to apply clinically, and so I don't give it for GI bleeds or intracranial hemorrhage unless a trauma surgeon just bosses me around and tells me to do that. So I give TXA. I looked really hard to find the original paper that looked at 2 gram bolus of TXA because we used to give 1 gram over 10 minutes and then 1 gram over 8 hours. And then it seemed like overnight we just sort of like changed. And then I talked to my friend, and basically what she had came up with was, and what I'd been told but I never really found was that Ranger Regiment was probably 75th Ranger Regiment was probably the first people to start doing 2 grams. And they looked at it and said, yo, we give 2 grams anyway. This is really logistically annoying to give one now and like one over 8 hours. Let's just see what happens when we push 2 grams as a slow IV push. And they started doing that, and it was fine. And so now, like at major trauma centers, the standard is basically 2 gram bolus. That's what we do where I work. I work at a level 1 trauma center at one of the places, obviously not here, where there's like literally a bed behind you where I sleep at night. But at one of the places where I work, 2 gram bolus. Ranger Regiment sort of made it up. That's kind of how a lot of medicine works, but they were just the first to do it because they can. So that's where the 2 grams come from. There is no like original landmark paper on that. Cool. We're now onto the blood section. This is one of the you know, the sexier sections, I suppose. You're starting to give, you know, donated blood like to people who are trauma patients. It's pretty legit. I had a staff scream at a co-resident of mine when I was in training, referring to the blood as the Lazarus juice. For those of you who are uninitiated in the Bible or whatever, Lazarus rose from the dead. You know, I don't think he got whole blood. I don't know what Jesus gave him or whoever saved him, but, you know, maybe Lazarus was the first walking blood bank recipient. I don't know, but he did, you know, come back from the dead. And this particular staff member referred to blood as Lazarus juice, which I find particularly hilarious. Taylor Swift, and I forgot this person's name. This was a funny meme that I found. We all get very excited when we start talking about whole blood and TXA for traumatic hemorrhage. Everybody loves trauma. They get like such a thrill out of trauma. Okay, it's just like them at a Chiefs game. The other one, this is my personal favorite one. This was on my blood cooler when I was deployed. I printed it out huge and I taped it down with a million pieces of clear tape so no one would ever get rid of it. But blood for the blood god. We worship at the altar of the blood god, particularly the whole blood god if you can get a hold of it. But, you know, I will settle for his, you know, lesser, you know, angels of component therapy if I have to. Cool. Here's the guideline. This one's long. I'm going to try to read it fast. It sort of gets into the weeds. It repeats itself several times. It's sort of unwieldy, but, you know, whatever. They didn't ask me to write it. Assess for hemorrhagic shock, alter mental status. If you have a brain injury, watch out for that, and or weak radial pulse. If you need to give resuscitation fluids for hemorrhagic shock, these are the most preferred to the least preferred in this order. Cold, stored, low titer O whole blood. Pre-screened, low titer O fresh whole blood. Plasma, RBCs, and platelets in a 1:1:1 ratio. We'll talk about that. Plasma and RBCs in a 1:1 ratio. And plasma or RBCs alone. Okay? You'll notice there is no normal saline on there. There was no albumin on there. There was no Hextend or Hetastarch or whatever, like Gatorade. Like there's no other stuff. This is the stuff they're bleeding. Give them the stuff they're bleeding. Okay. Do hypothermia prevention if you're doing this. If they are not in shock, then they don't need IV fluids. And if they can drink by mouth, they can drink by mouth. Cool. If they are in shock and blood products are available under an approved command or theater blood product administration protocol, every theater is different, every commander is different, follow your rules. Give them with cold, stored, low titer O whole blood. It basically says the same thing over. The pre-screened low titer fresh whole blood. Or if it's not available, 1:1:1, plasma RBCs and platelets. Or if not available, same thing. Okay? Or they throw in this one, which they didn't have in the first one, which I can't understand why, is reconstituted dried plasma, liquid plasma, or thawed plasma, or RBCs alone. I guess they sort of say it like here plasma or RBCs alone, but they sort of go further and say reconstituted plasma. So like freeze-dried plasma, that's a thing that we have available to us in some theaters, and so you can give that if you don't have anything else. Reassess casualty after each unit. Continue resuscitation until palpable radial pulse, which we said was at least 70 probably. Improved mental status or a systolic BP of 100 millimeters of mercury. So resuscitate to 100 if you can. If you don't have a manometer, you get on the blood pressure cuff. You can do it until they have a palpable radial pulse and improved mental status. Discontinue fluid administration when one or more of the following endpoints has been achieved. If you give them blood, give them calcium. So I think this is written a little weird, and so we're going to talk about this later, but if blood products are transfused, administer 1 gram of calcium. Okay? This is the important phrase, 1 gram of calcium, which is 30 milliliters of calcium gluconate, or it's 10 milliliters of calcium chloride. They're both 10%. Why is this different? Well, we'll talk about that in a little bit. But calcium gluconate is 30 mLs, calcium chloride is 10 mLs. We'll talk about that. given the increased risk of potentially lethal hemolytic reactions, transfusion of unscreened Group O fresh whole blood type or type-specific fresh whole blood should only be performed under appropriate medical direction by trained personnel. I believe this down to my bones. Yo, people want to talk about walking blood bank. That's fine. That's super cool. Really can save someone. You could also straight up murder someone. So this is harder than 75th Ranger Regiment may have you believe. And the only reason they're good at it is they train on it every single chance available. All their people are pre-screened. They have pre-selected donors prior to the shooting starting, so they know who's going to be their donors. They tire them beforehand, and so like everybody wants to be a cowboy until some cowboy stuff goes down. And so just like walking blood bank has a legitimate place in the resuscitation of trauma patients in the combat environment, but watch out. You can hurt somebody by doing it wrong, so you really got to pay attention when you're doing this. There are whole protocols on this. That this is beyond the scope of this lecture. One day we will talk about walking blood bank, but if it's harder, what should I say? It's harder to do than it is to say. So just be safe. If you're going to give somebody transfusion should occur as soon as possible after life-threatening hemorrhage. If you're going to save them, don't wait till they're almost dead to save them. Save them before they're almost dead. Okay? If you give them Rh negative blood products, if Rh negative blood products, that just means O negative. Okay? Don't get confused by the Rh. Some people get confused by that. That just means negative. You know, O negative, B negative, whatever. O negative blood products are not immediately available. You can give them O positive. That's fine. Should be used in hemorrhagic shock. If they're childbearing age female, there are things to do about that later. But again, beyond the scope of the course, save their life. If you have most of the blood you'll get is O positive. It's not going to be O negative. If a casualty with altered mental status due to suspected TBI has a weaker absent pulse, resuscitate them as needed to restore a normal radial pulse. And if you have BP monitoring, you can resuscitate them up to 110 systolic because you want to increase perfusion to their brain. Reassess frequently. If shock reoccurs, recheck all the hemorrhagic controls that you've done to make sure they're not bleeding, and repeat the fluid administration if you need to. Okay, that's a lot. That's the largest part of the entire section. We're over time, so sorry about that. But again, they didn't ask me to write it. That section's long, but it's really important. It's long because it's important. Giving people donor blood is dangerous. Giving people donor blood also saves their life. So you have to do it right to save their life and not kill them, and you have to know when to stop, because donated blood is a precious resource given to you by the person who donated it. Don't waste it. But if the person is dying, if they're dying to death, they obviously do need the blood. Okay, my thoughts. I found this meme too. I liked that, so we're going to preach. You bleed more than RBCs. Okay, you definitely bleed more than RBCs, so we don't just want to give people, packed red blood cells. They're bleeding plasma, they're bleeding their coagulation proteins, they're bleeding platelets, and so you need to give that stuff. The military is moving to low titer whole blood and all their blood resupply across the whole earth. That being said, when I was deployed, did we have whole blood? No, we did not. I was deployed to a sort of lateral location, a lower risk location, but people did get hurt there. We did give blood transfusions while I was there for trauma patients, and we did not have whole blood. And so the Army's moving, the whole military is moving to whole blood, but these things take time. So you may have component therapy, but whole blood, if you have it, whole blood is the way. I think you should definitely use it if you have it. The whole blood has the platelets, it has the proteins, it has everything in it that you need. It has better hemostasis. The younger it is, if you will, the longer it stays stored, it loses some of its superpowers. But the certainly fresh whole blood, or only cold stored whole blood that hasn't been around that long, certainly does have a pretty impressive hemostatic powers. That's how I like to think of it. Keep going. Walking blood bank is harder than it sounds. I sort of already touched on this. Ranger Regiment's really good at it. The Special Operations guys are really good at it. JSTOC's really good at it. Even big combat units can be good at it, specifically if they are in single service. So like the Army only is deployed to one location. They can get good at that. The Navy only, the Marine Corps only, or the Air Force only. When you start mixing in different units with your walking blood bank needs, it becomes a little complicated because you don't have access to all their stuff and you don't know who's titered or not titered. And so walking blood bank can be done good, done well. It's very resource heavy, but it can save lives. It also can be done quite well in the really small team environment because you really know your team members. Okay. Landmark paper alert. So my landmark paper alert dance, and then I swear to God, we're almost done. This guy, Matthew Borgman, wrote this paper. This was the paper that discovered one-to-one-to-one, basically. This paper's old, right? 2007. You guys probably think that that's old, but that's when I graduated high school, I guess. So it's pretty old. It was in the Journal of Trauma. This was a massive paper. This guy, Matthew Borgman, actually a pediatrician, not a trauma surgeon, not even a general surgeon. He's a pediatrician. I think he does peds critical care now. But yeah, he changed the way we give blood. He sort of found it during his residency project, I believe, is the story. This paper, retrospective, practice changing in the military. Sorry, I'm reading off my notes here. Practice changing in the military at the time. It was retrospective, 246 patients at U.S. Army combat hospitals who received massive transfusions, which was defined as greater than 10 units of PRBCs in 24 hours. Okay, so these people were super sick. They got tons of blood, and basically what he looked at was the ratio of PRBCs to other products. Okay, so he used a ratio of low, medium, or high. The low group was basically 1 unit of plasma for every 8 units of PRBCs, about ish. The medium was 1 unit of plasma for every 2.5 units of PRBC. So PRBC stands for packed red blood cells, just so we're all tracking if I haven't said that. The other was the high ratio, which was 1 unit of plasma for every 1.4 units of PRBCs. Okay, so this is like an average. They basically controlled for same injury severity scores, so people were essentially equally sick across the board. And then I'm just going to read off like the mortality. I don't think I have them written on here, but I'm going to read off the mortality rates, which are quite impressive. So in the low group, so people who got more PRBCs than plasma in a crazy high ratio, 8-to-1, their mortality, average mortality was 65%. So that's like bad, like 6.5 out of 10 people dead. The medium group, so 1 unit of plasma to every 2.5 units of PRBCs, their mortality, almost 30 points lower. Sorry, actually 31 points lower. It was 34%. Okay. Then the mortality of the high ratio, so the nearly 1-to-1 ratio of PRBCs to plasma, their mortality was 19%. So difference between, the high group of 65% down to 19%, massive difference overall. And then their hemorrhage mortality, so those were the overall mortality rates. That means like infection, surgical complications, head trauma, whatever, but that's overall mortality. But their hemorrhage mortality rate, these people died of hemorrhage. The high group, the really high, like 1 plasma to 8 PRBCs, their mortality was like 92% from hemorrhhage. The middle group 78, and the high ratio 37%. So just massive benefit to this, and it changed how we resuscitate people forever until the next landmark paper comes out that says we're doing it wrong. Try to get 1-to-1-to-1 as much as you can. It talks about platelets in here. You're not gonna have platelets. Like you're just not gonna have them. The platelets don't live that long. 5 days at room temperature, 14 days if refrigerated. So they don't live that long. So you're probably not gonna have the platelets in a deployed environment. You're gonna get whole blood, or you're gonna get partition blood. Okay. So landmark paper 1-to-1-to-1. Preach 2.0. Calcium G versus calcium C. It's calcium gluconate versus calcium chloride. The reason you need to give 30 milliliters of calcium gluconate versus 10 milliliters of calcium chloride is because there is 3 times the amount of elemental calcium in calcium chloride than there is in calcium gluconate. You need to be careful where you put the calcium chloride. In a peripheral IV, it can sclerose the vein and you can lose your IV access. So it should be given through an IO or central line, or a really good, really big PIV at your own risk. The standard teaching will be it doesn't go through a peripheral IV, and you should give calcium gluconate instead. Calcium gluconate, you need the pushes 30 mLs, okay, to get 1 gram of calcium. We give calcium to people for a couple reasons. 1, it's part of the deadly diamond, which has already previously been discussed. But 2, citrate in the bags, the transfusion bags, it chelates, means it pulls out calcium from your body, basically, and it makes you hypocalcemic. It lowers your calcium, which worsens your vasomotor tone. It worsens your cardiac contractility, making your blood pressure go down, your cardiac output go down. So if you are going to give blood products to somebody, you should give them calcium. If you are giving blood products to people, every 3 or 4 units, you should give additional calcium. Okay? Normal saline isn't normal. There's nothing normal about normal saline. Okay, so you noticed on the TCCC guidelines, there was no mention of normal saline, plasma-lyte, lactated ringers, albumin, whatever other stuff. Okay, there's nothing else on there. Normal saline is very acidotic, it's hyperchloremic, it's hypertonic. Basically, it messes with the osmolarity of your blood and everything. It's not normal. There's nothing normal about normal saline. So if you have access to blood and you're giving normal saline to a hemorrhagic trauma patient, you are doing things wrong and you are making them worse. That being said, if you have nothing and their blood pressure is 50 and you just need to make it a few more minutes to get to a place that has blood, I'd give that. I would give that. If I was pre-hospital or I was at point of injury and I had the ability to get someone somewhere, I would give enough to make their blood pressure just high enough so they don't code, because it's easier to say, hey, look, I didn't have anything, but I got them to you alive, get them the blood, than to say, well, I had 2 bags of LR here, but I didn't want to give them because they're a trauma patient. There is some data that says that 1 to 2 liters of crystalloids does not change outcomes in trauma, so that goes against some of the other papers. But I won't say you're super evidence based to back up giving large volumes of crystalloids. But if you need to give a liter to save someone's life and you don't have any other way to keep them alive, I would definitely do that. Okay, don't be too dogmatic. Don't worship too much at the altar of the blood god that you let common sense go out the window. All right, last one. This is refractory shock. It says if the person is in refractory shock, basically treat tension pneumo. That's kind of what it says. Decompress the other side of the chest as well. We're way over time. We're 32 minutes. This is ridiculous. Sorry, this one took me a while to come up with, but it's an important guideline. It's an important section, okay? But we made it. We're at the end. I'll give you my final thoughts, and then I'll let you get on your way. Stop the bleeding. Stop the bleeding, stop the bleeding, stop the bleeding. That's always going to be important. Number 1 cause of preventable death on the battlefield. We've talked about that a million times. Seriously, though, make sure they aren't bleeding. Stick something in them that you can give blood through, okay? Your chest tubes don't help. Your crike doesn't help. Foley catheter doesn't help. Give them an IV, give them an IO. Use the GAHP thing if you have to plump up their vasculature. Give them something that you can give blood through. TXA all day. Send it on the TXA. Give it to them. 2 grams IV push, slow push. No problems with TXA. Give the right blood in the right ratio. They're not going to be thankful to you if they die because you just gave them a bunch of PRBCs and you didn't give them any plasma, or you didn't give them the whole blood that you have available. Okay, remember your priorities: cold stored whole blood, fresh whole blood, 1-to-1-to-1, 1-to-1 plasma RBCs, freeze-dried plasma if you have to, plasma only, RBCs only. Follow the right protocol. Pelvic binders are useless, but they will prevent you from getting yelled at, and you should do them. This is not like civilian trauma where a patient's going to be transferred one time. There may be many transports for this patient, and so, is there a benefit that we can't measure for combat trauma patients who are going to go to multiple places during the course of their sickness with a pelvic binder in place? Sure, maybe. I don't know. If I was downrange and somebody got blown up and they had a pelvic fracture, I would put a pelvic binder on them, and then I would say, cool, that did nothing. Let's move on and let's save their life. If they get worse, reassess your stuff. If a person who's getting better gets worse, you need to reassess your stuff. Where are they bleeding from? Why is your stuff not working? If they don't get any better at all and they continue just to get worse, then you probably don't have hemorrhage controlled, or you're missing something. You're missing the tension pneumothorax, you're missing the airway obstruction, you have bleeding happening elsewhere, so reassess your stuff. As always, trust your gut, do your best every single damn day. Always, always, always stay in the fight. Stay in the fight, help your teammates out, help your trauma patients out. They need you. They need you, they need you, they need you. They need you to be at your absolute best, and you can do it. Here's my sources if anyone wants to look up any of this stuff and see if I misinterpreted any of the data. I'm excited to see you guys. I'm excited to see you this weekend. Feel free to share these. Share the links out. I don't get any money from them or whatever. I don't have any ad revenue. Just send them out to people. If you have a friend who's an Army medic that lives in Connecticut, send it to them. And a person who's a Navy corpsman in San Diego, send it to them. If you want to send it to your college professor that say TXA sucks, send it to them too. They're probably dumb and I can educate them. But send it to anybody. And again, feel free to email me, text me, call me. My email will be on the on the emails that I send you. My phone number's on there too, so feel free to hit me up whenever, and I'm excited to hear what you guys have to say about these. Thanks so much.